Welcome to this explainer. As clinicians, auditory brainstem evoked potentials are absolutely a cornerstone of our practice, right? But today, we're going way beyond the basics. We're going to look closely at the exact stimulus types, the nitty-gritty signal processing parameters, and the precise neuroanatomy that actually make up a robust ABR clinical guide. So if you're looking to objectively measure hearing and pinpoint neurological issues with real precision, you are exactly in the right place. Let's get into it. I really want to kick things off with this brilliant quote from Dr. Ananthanayaran Krishnan, the author of the foundational text we're drawing from today. He urges us to, quote, practice at the top of your license rather than merely be a technician. It's such a crucial reminder. As clinicians, we have to truly understand the intimate relationship between our data acquisition protocols and the underlying neuroanatomy. We aren't just here to push buttons on a machine, get a printout, and call it a day. No way. We're here to critically interpret the incredibly complex physiological reality behind those waveforms. Here is our clinical roadmap for today. 1. The magic of ABR. 2. Selecting the right stimulus. 3. Mapping the auditory brainstem. 4. Signal processing secrets. 5. Quality control and averaging. And finally, 6. Beyond the basic audiogram. Okay, Section 1. The magic of ABR. Reading the brain's electrical whispers. At its core, when we're recording an ABR, we are detecting microscopic electrical events that unfold sequentially. Think about it. A brief sound hits the ear, and it immediately triggers neural activity that travels from the auditory nerve all the way up through the nuclei and tracks in the brainstem. What we are actually seeing on our screens is the volume-conducted neural activity of this entire pathway. Now, as clinicians, we know these far-field potentials are incredibly small. We are picking them up from scalp electrodes, which means these synchronized neural firings literally have to travel through cerebral spinal fluid, bone, and tissue before they even reach our equipment. It's just an extraordinary physical phenomenon, and it essentially lets us evaluate our patients' neural function in real time without them having to say a single word. Moving right along to Section 2, selecting the right stimulus, the origin of the signal. Our choice of sound, whether that's a click, a tone burst, or a chirp, completely dictates the exact breadth and timing of the cochlear response we're going to capture. If you want a really robust, highly synchronized response across a wide area, you're going to use a click. That abrupt onset perfectly triggers those onset-sensitive neurons. But as we all know, clicks just don't give us the frequency specificity we need to build a complete audiometric profile. For that, we need a tone burst. Its gradual rise-fall time engages a much more restricted cochlear region. And then we have the chirp. The chirp is actually engineered specifically to compensate for the natural traveling wave delay of the basilar membrane. Because lower frequencies naturally take longer to reach the apex of the cochlea, a chirp delivers those lower frequencies first. This means all the frequencies reach the respective cochlear regions at the exact same time. The result? A highly synchronous and incredibly robust neural response. It's pretty amazing. Which brings us to Section 3, mapping the auditory brainstem, the pathway. This is where we really start blending audiology directly with neuroanatomy. By mapping these electrical potentials to their anatomical generators, we aren't just staring at random squiggly lines on a screen. We are actively tracking highly specific physiological structures in real time as the auditory signal travels inward. The absolute key for our diagnostics is tracing specific waveform peaks directly to their anatomical generators. So, wave 1, that is the compound action potential of the distal portion of the auditory nerve. As we trace that signal centrally, waves 1, 2, and 3 have significant contributions from the cochlear nucleus. Wave 3 is heavily tied to the superior olivary complex, which is absolutely vital because it's our first point of binaural interaction in the pathway. And then there's that highly robust wave 5 that we rely on so heavily for threshold estimation. That reflects neural activity in the lateral lemniscus and the inferior colliculus right up in the midbrain. Knowing this mapping intimately is exactly what allows us to confidently use ABR for site of lesion testing. If we spot an abnormal interwave latency, say between waves 1 and 3, we can pinpoint exactly where a retrocochlear pathology, like an acoustic neuroma, might be compressing the nerve or the brainstem. All right, Section 4, signal processing secrets, the extraction. Remember, we are dealing with signals on the scale of fractions of a microvolt, completely buried in a massive sea of background electrical noise from the patient's own body. We're talking muscle activity, random EEG waves, even environmental electrical interference. When you're fighting excessive patient EEG noise, these 4 sequential steps are literally what save your data. We always start with low impedance electrodes because matching the impedance across the skin is absolutely crucial for maximizing the common mode rejection ratio. Next, the differential amplifier does the heavy lifting. It takes the input from 2 electrodes, inverts the polarity of one, and adds them together,
so any random background noise common to both electrodes mathematically cancels out, while our auditory signal, which actually differs between the sites, is amplified. Then we apply precise bandpass filtering to strip away any frequencies outside our target range. And finally, signal averaging. Since the ABR is strictly time-locked to our stimulus, repeating that sound thousands of times makes the true neural response grow, while all that random, non-time-locked background noise effectively cancels itself out.
Moving to Section 5, Quality Control and Averaging, Refining the Signal. To completely avoid misdiagnosis, we have to constantly measure the statistical quality of our recorded waveform. We rely heavily on the signal-to-noise ratio, or SNR. Modern systems calculate a residual noise estimate, often by taking half the sweeps, subtracting the other half, and just analyzing what random noise is left over. By comparing our actual average response to this estimated noise variance, we can mathematically confirm, are we looking at a true neural response, or is it just artifact? This brings us to a huge clinical time saver based on that SNR concept, the F-SPA ratio. Research by Elberling and Dawn established this ratio, which estimates the variance of the background noise at a single fixed time. Here is the magic number. If your F-SPA ratio reaches 3.1 or greater after a minimum of 250 sweeps, you have a 99% statistical confidence that a real neural response is present. So, what does this mean for you in practice? It means you can automatically stop averaging early. You save yourself and your patient valuable time in the clinic, absolutely without compromising your diagnostic accuracy. Finally, Section 6, Beyond the Basic Audiogram, Complex Sounds. We are moving far, far beyond the simple click or tone bursts now. Today, researchers and forward-thinking clinicians are using envelope-following responses and frequency-following responses to evaluate how the nervous system encodes the really complex temporal features of actual speech. Imagine presenting speech syllables like ba and da, and being able to record a sustained brainstem response that literally mimics the fundamental frequency and harmonics of that exact speech sound. We can use this to evaluate how hearing impairment degrades the neural encoding of speech. And even more exciting, we can use it to test and fine-tune the signal processing algorithms inside hearing aids and cochlear implants. So it leaves us with a pretty thrilling question to ponder as clinicians. If we can reliably map a single simple click all the way from the cochlea up to the inferior colliculus, just imagine what we are going to uncover as we continue to decode how the brain processes the complex, beautiful symphony of human speech. Keep pushing the boundaries of your clinical data and keep practicing at the top of your license. Thanks for joining me for this explainer.